if sleep apnea affects close to 1 billion people worldwide, and more than 80% of them don't have a diagnosis, the question I ask every dental team that I train isn't how do we treat this? It's why aren't we screening every single patient who sits in our chair? Because we already see them. The primary care visit they're missing, we're not missing. So why are we still only screening the patients who happen to mention that they're tired or that they snore? In every training I run for dental teams, this is the first thing I have to correct. Sleep apnea doesn't look like one thing. It's not just the patient who fits the stereotype. It's the 34-year-old who's never been screened for anything in her life because no one thought to ask. Building a program where every patient gets screened, not just the ones who raise their hand, is a workflow problem before it's a clinical problem. That's where most practices get stuck, and it's most of what I actually teach. Screening is only half the problem. The other half is what happens after, and honestly, that's where I've watched the most well-intentioned programs fail. You flag a risk, and then the patient hits a wall. No sleep physician taking new patients for 3 to 6 months, no coverage in their area, no time to take off work for an in-person consult. Access isn't a side issue in this field, it is the issue. If we can't get a flagged patient in front of a qualified physician quickly, the screening was just paperwork. Telemedicine is not a replacement for that physician. It's what lets one sleep specialist reach patients who'd otherwise wait months, especially outside the metro areas. I want to be honest about something most training in this space glosses over. Implementation is hard on both sides of the referral. Dental teams don't have a clean, defensible way to document risk, and they're worried about scope of practice. Medical teams get referrals with no standardized data attached, so they can't triage efficiently, and patients fall through the cracks in the handoff. I didn't fix this by finding a single tool. I fixed this by rebuilding the workflow on both ends. On my side, that starts with the screening tool itself, the Solish Face X Scan. A study pairing facial photography with the Stop Bang questionnaire found a 97.2% AUC and about 92% accuracy for identifying moderate to severe OSA, meaningfully better than either tool used alone. But the number really isn't the point. What matters clinically is the report it gives me. Something concrete to put in front of a patient and say, here's what we're seeing, here's why it matters, here's what happens next. It turns a vague conversation about being tired or snoring into a specific one about airway risk that actually opens the door. And what happens in that door matters more than people think. If I hand a patient a name and a phone number and send them off to schedule on their own, months can go by, if they call at all. But if I can offer them a real choice, right there in my chair, a local sleep physician they already trust, or a telemedicine visit with a group like Arima Health that I can help get on the calendar before they leave that same day, the difference in follow-through is significant. In my experience with patients who leave with a sleep appointment with the sleep physician already booked, complete the screening to diagnosis process at a meaningfully higher rate than patients who leave with my best wishes and a slip of paper in their hand. But even a fast referral isn't the finish line. Sleep apnea is a chronic condition. It needs longitudinal management, not a single successful handoff. That means the dental team and the medical team staying in the loop with each other, sharing outcomes, adjusting therapy, checking in on adherence 6 months and every year later, not just at intake. That's the direction the field is already moving. Physician-led, team-delivered, with dental teams carrying real responsibility for long-term adherence, not just the handoff. The practices I train that succeed long-term are the ones that treat this as a shared ongoing care between medicine and dentistry. Not just we've screened them, we referred them, we're done. That's the model I'm trying to move the whole field toward. This is what I teach, what I write about, and what I'm building at Dynamic Dental Sleep and Sleep Thrive Live. Not a single scan or a single referral, but a real system. Screen everyone, get them to care fast, and keep them in care long enough for it to actually work. Sleep better, feel better, live better. but only if we build the right pathway that actually gets them there. I'm Dr. Ashley Spooner, and this is what I teach dental teams to build.